Okay, we are now live. Um, and it's kind of near and dear with regards to our preventive cardiology clinic that we run. Leslie's on here with me, and also, having come back from the round or heart house roundtable. And for those that don't know, the American College of Cardiology has since the early mid 2000 era, I think 2006 or seven, they started having these roundtables, and it's at the Heart House in Washington D.C. And essentially, you would find a topic that was of interest, that was needed to be discussed by experts in the field, that we didn't have either guidelines or a white paper or anything to kind of move us forward. And hopefully you've seen that over the last 4 to 5 years, anyways, it's become top of mind with these therapies that are reaching weight loss uh, almost almost comparable to bariatric surgery. When we think of bariatric surgery, we're thinking of like 25% or more weight loss. And folks are like, that's pretty invasive. There's a whole different lifestyle that's involved, etc. And then with these injectables, GLP-1 in particular, we're seeing weight loss of 14% or more. And then you start to get to dual incretin, and you're seeing 20%. And now there's a triple incretin on its way, with phase 2 trials showing up to 25, 26% weight loss. So, are we heading towards a trial of triple incretin versus bariatric? I don't know, but I'm just happy that there are now therapies out there for patients. And so the question here is, how do we approach this? Is this vanity? Is this just a choice? I want to be obese. Or is this truly a dysfunction, endocrinologic dysfunction, that we need to address because it has so many other downstream sequelae? So hopefully that's a good intro into why I thought this would be important for nephrology, but for our cardiovascular partners who are also joining here. So I did want to discuss a little bit of the epidemiology of obesity. God, how do we even approach this with BMI, and are there other tools that we should be utilizing? Kind of some of the dynamics that are involved in obesity. Because outside of this, and this was part of the discussion, I was in the room with 42 experts. I'm not an expert, but I feel like I know something about this. These were folks that were obesity specific physicians, heart failures, cardiology, there's lipidology, preventive, etc. And it kind of came down to, like, the experience that we have as clinicians is that so many patients are have the onus placed on them in terms of their weight, and that's just wrong. I think as human beings that's wrong, but as clinicians, we need to be thinking a little bit more towards care and recognition of disease rather than blame. And then we'll go through the pharmacologic therapies out there, including bariatric surgical ways to approach weight management. So this is a fun slide, I think. I guess not fun, but I mean, look at the time frame here, as it's going forward from 95 on. And what we're seeing here is, commensurate with diabetes, and kind of diabetes is lagging just a little bit. Obesity, as defined as BMI greater than or equal to 30, is just coming across the United States in waves. And, this is 2009 right here. This is greater than 26% of the population in that red. And that's just the 2010, folks. I didn't include the last 14 years, which it's even more stark with regards to age-adjusted prevalence of obesity. We're heading towards nearly 35-40% of the population that'll have a BMI of greater than or equal to 30. And I won't be shy and say that I am included in that, because my BMI is 30. So as we kind of think about this then, why do we do this? Why should we even think about it? Well, this is what happens when you help patients with weight management. If they've already had disease, comorbid diseases, or they're heading towards it, as you lose weight as a percentage of their body, what starts to happen is a reversal of other diseases that come out from weight. Now, it's not one to one. Not everyone that is categorized as having obesity will have these comorbid conditions. But because of those because of uh, its impact on the body and different endocrine systems, these are the diseases that tend to come out. And it's not, it's not just diabetes. Okay, so remember, there's metabolic non-alcoholic disease here, steatohepatitis, so metabolic disease, if fatty liver disease, etc. So here, I think I kind of want to introduce up front some of the pillars that have come forth in terms of obesity management. So I mean, we tend to focus, and I'm a party to this. I focus a lot on pharmacologic therapies just because my excitement in terms of the benefit and the success we've seen in pharmacologic therapy now in the current era. But you'll see that, in the list here is naltrexone, bupropion, orlistat, or as a friend of mine likes to say, orlistat, because of its side effect. But then bariatric surgery. But lest we forget, a lot of this can be behavioral, and I think part of the behavioral part of it is infrastructure. We don't really have infrastructure that supports the behavioral changes that people. It's in our society. It makes it easy for people to make the wrong choices, and you have to work hard to make the right choice. And so when you're set up that way, it doesn't happen very often that folks can overcome poor behaviors. So, how do we define obesity? I mean, I think this is really important because we're talking about this disease and or this circumstance, I guess. I look at it as a disease, but it also is a circumstance. And these are the BMI cutoffs, and you can argue. I won't argue whether or not BMI is good. I'll just say that it is one standardized way of at least getting to weight, height, um, and applying it epidemiologically to folks. So as we kind of think of a population basis, here is one way to look at it, and you'll see that overweight starts at 25 in those that are not Asian, and then in Asians for overweight, 23 is where it starts. You'll see here that they say 25 for obesity, and it depends on what you're looking at. Folks, and some guidelines have 27, but I think this is reasonable when we're setting overweight at 23. That 25 starts to identify obese folks of Asian descent. And then over here, it's 30. Okay, so here are the guidelines. BMI is kind of stuck with us because it's in the ICD 9, 10, and now 11 codes that are coming. So, for lack of anything else, we're kind of solidified into that because they're kind of immortalized in how we bill things. So, anyways, I don't know if you have any questions on that, but it's always, happy, or excuse me, I don't have any questions on that, but certainly put them in the chat as we move forward. So here's kind of the prevalence that is, the U.S. You just kind of saw that CDC journey through 1995 to 2010, but this is kind of the 2020 information that we have, and that's now 42%. Yeah, that meet the criteria of BMI greater than or equal to 30. And then we have nearly 1 in 10 individuals that are in the BMI 40 or higher. And I think we are a little bit biased in the medical community because, again, these are the folks that have other sequelae. We're probably seeing them more than we are the general population. So I would say that I do actually see more than 1 in 10 that meet a BMI of 40 or greater, but probably more than 40% of my patients meet a BMI of 30 or greater. And then I think the thing is it starts young, and 20% of our children are in that 95th percentile or greater than 95th percentile for their weight. So it starts early, and we need to reach downwards to the children, and forestall some of those behaviors that lead to adulthood obesity. So here is a global perspective. When you consider right now we have nearly 8 billion people on this earth. That's children included. And so from an adult perspective, it's probably a ratio of, 6 to, ratio of 60% to 30%, or 50 to, or 60 to 40%, in terms of adults. And so by percentage, it's a lot of adults that are obese in the world. So then I throw this next one in because I think the question is this nature or nurture? So if we look at twins and we assess them in either the same environment or different environments, what will happen? And morphologically, at least from twin standpoint, often twins that are not fraternal anyways. I'm forgetting the word. I apologize. You're welcome to type it in and correct me. But you can see morphologically and genetically, there is something that drives this. Of course, these twins often live together. So you would say nature and nurture are involved here. But then look at the fraternal twins. And, they're living in the same household. So there is very similar nurture that's going on in these individuals. And there's a component of genetics that we cannot forget. So, don't think people are blaming just their genetics that they are the way they are. There is a reality to this that drives obesity, regardless of whether you live in the same household or not. And certainly if you live in the same household and those genetics show you the same morphology, but different morphology here, then there's some genetic component to obesity. So what's the full cause? There's the obesogenic environment, which is what I was talking about. Structurally or infrastructural, we've got a lot of things that we're up against as human beings. And so there's all of this, and then you add on access to excess calories. We just have really high dense caloric foods that are available, and they're the cheapest type that are available. But you add on kind of our life as lived here in the U.S. and of course in other places. But then the genetic susceptibility, and that includes epigenetics. And for those not familiar, it's not that you inherited mutations, but something that impacts one generation can then, on an epigenetic level, can be passed on to the next generation. We've seen this in like World War I and II, where folks were kept in prison camps, and how that impacted the next generation of those individuals, the descendants of those versus other folks that lived at the same time and moved forward. So epigenetics can, we have changes in our proteomics, our proteins, that will be kind of passed on to the next generation. So I think it's important that we have kind of set points, and that this is kind of what happens. Remember, by evolution, we're kind of hunter-gatherers. We were not built as agriculture folks to stay in one space and create food that would be available on a regular basis. We, move from place to place. It's from a societal standpoint that we've changed that from hunter-gatherer to an agricultural and stable diet. And the body was meant to defend highest fat mass. When you're in a hunter-gatherer situation with days and up to a week or so without food, the body's like, I'm holding on to everything I can. It conserves it. So it doesn't know that you've moved on in society. It hasn't evolved as quickly as we have, relatively speaking, in time. And so when you have a normal weight and you gain weight, this is the body says, I'm going to defend that weight. It makes it harder to go backwards, and it will deploy endocrinologic things, hormones, that will try to defend that mass. That's just kind of how it works. And that includes folks plateauing and the body's defending, holding on to weight, even when they're at 500 calories or less for long periods of time. It's like they will not lose any further weight. And so the body, as it gains weight, it will hold weight. Gains weight, it holds that weight. And this is a biologic and physiologic adaptation. So when you start to lose weight, what is the body doing? So from a physiologic standpoint or biologic, it will increase ghrelin. This is a hunger hormone. It's like, uh-oh, I'm losing weight. I better tell the guy upstairs or the gal upstairs that they need to eat more. This is not good. So ghrelin tells you you're hungry. And there are folks that have food noise, like they cannot stop thinking about food. And it's not because psychologically they're damaged. Their body's saying you're hungry, even when you're not. So it's trying to defend that weight, and ghrelin will go up. And then guess what? Look at GLP-1, GIP. This is tirzepatide. I mean, these are receptor agonists that are in tirzepatide. These are natural incretins that the body uses to help adjust our satiety and what we think about food. So when you're agonizing those receptors and leaving GLP-1 longer in the body, it only really lasts an hour naturally. And so then when you're injecting and seeing it last for up to a week, that's pretty cool stuff. So GLP-1, GIP, these are the ones that are satiety. But guess what naturally the body does? It's like, no, you are not satisfied. In fact, you're hungry. And this is the body's way of defending this new fat mass, this new body weight. On the other side, physiologically, we tend to, as we lose weight, well, there's less mass to, you know, um, use up energy. And so our resting energy will drop. Our caloric output drops. We become more efficient in terms of utilization of energy in our muscles. And a lot of that is related to leptin. Okay. So there is a biology to this. There is a dysfunction that is happening endocrinologically. We wouldn't say that diabetes is just a choice, right? There is endocrinologic dysfunction that is occurring. And so same thing happens with obesity. And it's so important to recognize so that as we're discussing this with patients, we know the person in front of us, this is what's occurring in real time for them as they've tried to lose weight. And then here's, some more pathogenesis of obesity related morbidity. So meaning, what are the sequelae? What comes out of obesity? Well, we have this capacity to store excess energy. In fact, we welcome it because we're trying to hold it for a time when we are in a starvation state, or we're not going to have food for a time, right? But the normal is that we just increase subcutaneous fat and store that for a time and then use it. But when it's impaired, what happens is that it deposits in the wrong area. So there's ectopic fat deposition, and then there's visceral. And it's really this visceral fat deposition, a fat that starts to sit around organs or within the organs, such as fatty liver disease, but like epicardial fat along the cardia, or the heart rather, will impair how hormones interact with those structures. And so it's so important to recognize that the person that's in front of you, they're starting to have this impairment, but their morphology can help define that too. That's why we think of like pear shaped versus apple shaped. Those that are apple shaped tend to be more visceral fat. It's depositing in this area, and they're at more risk than if we were looking at someone that's pear shaped and it's depositing more peripherally or in the extremities away from those organs. So there's a difference also that occurs in terms of where that fat is depositing. Now, I think it's important for us, and again, I'll share the slide deck. I'm going to be adding some stuff later too, to make it more comprehensive for you. So hopefully that's helpful. Sorry, Kendall, did you have a question? Or no, Mike was on. Um, oh, They disappear. Okay. So, looking at this slide, hopefully we all recognize or have seen all of these therapies, but all of them have some type of effect on weight. Um, and if you can imagine, it's not like they slowed metabolism per se. These are impacting all sorts of areas in the cascade, including potentially satiety, making it less hunger. It might improve hunger. I mean, when I was working in oncology in my rotation, we used olanzapine a lot to help people gain weight when they were, losing so much weight during their cancer treatments. So there's a lot here to think about. And I think it's important to recognize these meds that we commonly use that will impact someone's weight to their detriment. Usually they're gaining weight. So here are other risk factors. I think they all make sense to us. I think, as you age, your metabolism does slow down. You're losing muscle mass. Of course, disparities that can happen with lower socioeconomic status, the access to more healthy foods. They tend to have more access to calorically dense, not healthy foods. And then physical inactivity in our current social structure of sitting down and 8 to 5 jobs at desks. And then just stresses, mental illnesses that also drive that. But the medications in mental illnesses can also drive weight increase. And then, I mean, if you're disrupting sleep, that it will impair just overall health and desire to be active and do those things that are good behaviors, right? Okay. So diagnostic or diagnosing and treating obesity. So here, I think, whoops, not sure why that happens. These are the diagnostic standards here for, where we're classing things. They're very similar to what I provided before, slightly different depending on whose criteria you're using, that was kind of a joke. The World Health Organization has the class 1, class 2, class 3 criteria. And so anyways, that's very similar here where we are class 1, class 2, and class 3. So I like this because now we're kind of like, okay, what's the diagnosis for some of the things that are related to obesity? And I think commonly, we don't have to look further than, this is 3 or more, but weight often is one of the standards for metabolic syndrome. That almost always when I'm calculating whether there's 3 or more pieces to metabolic syndrome in a patient, weight is like almost always in that calculation. Then I'm just looking for whether triglycerides or HDL or blood pressure is elevated, and often they have some type of impaired fasting glucose or some type of insulin resistance. So here, the waist circumference. Just as a question, how many of you have measured a waist circumference in the last 10 years? I will
just
say
my own.
Okay. Well, that's important though, right? That's important that you've
Maybe
done your
some
own.
kids.
Okay. So, I was waiting until they arrived to tell Leslie, but, back in our old clinic, I did actually ask our clinic manager to provide us with tape measures and to put them in rooms. They disappeared. Um, and I'm doing it again. But this time it's not just I had like the Taylor type of measurement, and that's always hard. People fumble it, etc. But this one is actually meant to measure waist circumference. So it has the handle and it has the thing that pull. They can pull it around and then just snap it back on there, and it allows them to measure. But I do want patients to feel comfortable with an infographic on why it's important. And should we have this discussion? Yes. But I want to normalize that it's okay to have a conversation on weight management and to get them to feel comfortable measuring their own waist circumference. And that will remind me to do it because I will have something like this up. Hey, there's this metabolic syndrome. Do you meet that criteria? Am I doing enough to optimize management of all of the things that will be part of your metabolic risk? So I think for me, it's a reminder, but it hopefully is an educator for the patient, and it makes them feel like, okay, if he does this on all of his patients, not just me, I'm not the one he's picking on, but he asks all of his patients to look at this. So anyways, that's what I'm working on. Here it's important because as you think of cardiovascular disease with metabolic syndrome. Again, we're calling this a syndrome, and there's a whole lot of things going on metabolically for these patients, but they have a 2-time increased risk over someone that doesn't have metabolic syndrome. And by the way, this is, the thing is here it's 5-fold increase of type 2 diabetes. But when you look at diabetic populations, whether they fit metabolic syndrome criteria or not, and you're like, shouldn't they all? No, glucose is only one part of that. It's only one part of that. So when you look at diabetic population that have diabetes and you start splitting out metabolic syndrome present or not, those people with metabolic syndrome do far worse. But then you go, well, okay, let's look at diabetes versus metabolic syndrome. Metabolic syndrome does worse than folks that have diabetes without metabolic syndrome. Like metabolic, no diabetes versus diabetic, no metabolic syndrome. It's the metabolic syndrome that does worse because there's so much more going on in those individuals. And then you can see the organ damage that occurs in these individuals, including chronic kidney disease, which is why we should all be worried about this in managing this cardiometabolic kidney disease or cardio-kidney metabolic disease. So here are the other tests. I'm not going to belabor this because I put this together originally for students, but it's important to recognize what you're looking for. And if you're interested in like, okay, beyond the kidney or beyond just my cardiac lipid stuff, are there things that I should be thinking about my patients? And I'd say, yes, we should all be cardio-kidney metabolic in our respective areas. I think our patients would be served well if we're thinking of these things. So at least once a visit in a year, you should be considering these and assessing it. And then, okay, so going to prevention strategies. Here, whatever, again, this was for students, but I think it's helpful that we know this. It's not like patients have heard this for the first time. Less screen time, move more, eat less. Please don't patronize patients. They have been doing this, and it's just helpful to remember in the back of your head that these are things that should come up naturally in conversation. So what have you been doing? Tell me about what's worked, what hasn't in terms of losing weight. And they will offer up, man, I've been doing this. I've been on a 500 calorie diet for the last 3 months, but I kept gaining weight instead. And then, then with this knowledge of the pathophysiology, you can explain why that happens and to not give up, but maybe there's a way that we can help support and augment weight loss and not further psychologically damage our patients. Okay, let's see. Why is that not going forward? All right. So again, just other things to kind of think about: eating meals as a family, using small plates. These are just important for us to remember, maybe even personally. And I will tell you that these are all the things that I've heard while I was in the OMADA program that Intermountain allows. Yes, I've been identified as pre-diabetic. Again, I've already said my BMI is greater than 30. So I will tell you that these were things that we discussed, me and the nutritionist. And I think it's important that we recognize how freaking hard this can be. If you have kids, it's not easy to corral everyone, and we're all so busy. So be gentle as you're like, okay, I can say these things, but maybe you can write them down and decide with your family what's the plan to help improve for them and for you, like more family time. So anyways, so this is a nice picture that reminds us, hey, plant forward, plant based, let's add more things that are colorful and fresh onto the dinner table. Okay. So, I often will talk about the Mediterranean diet. I just talked about the plant forward idea or plant based idea. I think there's much more data coming forward with regards to those that are moving into the plant forward or plant based diets. I don't mean vegan, I don't mean vegetarian, I do mean using more plants in your diet. And I think if you just start with that mindset, ultimately folks will start to edge out some of the refined sugars, a lot of the meats, etc., that are already in their diets. So, and it supports Mediterranean, which tends to have more, tree nuts and, of course, olive oil. Um, as a bonus, what was the amount of olive oil used per week in the PREDIMED study? Does anyone know? Any thoughts in the chat or 1 quart a week of olive oil that they asked them to use? I don't know if they were drinking it or cooking with it or just putting it on their salads, all of that, but they were asked to use 1 quart of olive oil a week and then tree nuts as well in their foods. Okay. So that I just all the things here that are important to think about in terms of what to do and then what not to do. I do think that folks inherently understand they've been bombarded with what you shouldn't do, that it's helpful to have something like this, but it's more helpful to help them understand like how to what things to eat, and then maybe some recipes that they can try. I'm a fussy eater, kind of. No, not really. I'm fussy because my kids are fussy, and so it takes planning in terms of trying some of these things. Okay. So now into the medical management of obesity. Um, this next, and you can listen to it on your own. And I don't mean this to be like in your face. So this next slide this is Boogie. Um, and we're not going to play it today, but I do think that you should take a listen to his story. I think it'll resonate, that if you've spent any time speaking to anyone that meets the obesity criteria, um, you'll have more empathy, I hope. Um, yeah. Anyways, so I'll just leave it at that. But I think it's always nice to hear a patient perspective, um, outside of the hustle and bustle of clinic, to have a moment and recognize that what Boogie will tell you of his experience is in some way, shape, and form what many folks who um, look like him and have weight management dysfunction, what their experience is. So here, as we kind of think of ACE, I really like the American Academy of Clinical Endocrinology. They do a really good job, and often they're a little bit more intensive in terms of their therapies and their forward thinking of treatment than we are in the cardiovascular space. And I don't know if that's the same in nephrology. And I often see their stuff is a little bit more intensive when compared to the American Diabetic Association as well. But this is a nice kind of way to think about staging for obesity. So step one is really kind of the look at, what is their BMI? So we've done this, right? We've gone through the cardiometabolic last week of stage 0 on to 4. And here they're like, okay, if you have a BMI of less than 25, they're not overweight or obese, unless they're Asian. And then, 23 is kind of your cutoff. But if they reach those criteria, if they get on the radar for being overweight or obese, the question then is, what is the prognosis of something bad happening, and what do you have to think about? Well, cardiometabolic disease or biomechanical. So, osteoarthritis, knee joint, all that stuff. And so you're kind of thinking, okay, often BMI greater than or equal to 25. If this person does not have any of these complications currently, then they're stage 0, And then you're kind of thinking about maybe some therapeutic targets, some treatment modalities, and then intensifying it based on whatever their staging was above. So if they're mild to moderate with complications and a BMI greater than or equal to 25, that includes, metabolic disease, or biomechanical, or if they're already starting to have like bilateral hip osteoarthritis, knee osteoarthritis, they have the beginnings, or they have diabetes and hypertension already. So then step two is looking at, okay, what do I add pharmacotherapeutic wise, and then of course lifestyle, but I caution that we don't come at this like they've never heard it before, but rather joining with them and saying, I know you've been through this process, and based on what you've told me, I think it would be nice to kind of revisit it as we add some augmentation and support you. And I think if we build this more intentionally, I'm your partner, I'm here with you. Let's see if we can move forward. So then just individualized in that care. Here, as folks are in that BMI greater than or equal to 35, and that's really kind of the cutoff we've seen in terms of referral, meaning like insurance will approve it at that point. But I've seen them approve at BMI at 30 if they have cardiovascular disease or sleep apnea or something else that's already occurred with that patient. But BMI greater than or equal to 35 by itself, if you came back up this way, meets criteria for gastric banding, sleeve, or bypass. Now, it's ironic and just terrible that a lot of insurances will ask the patient to try to lose weight before undergoing gastric banding. Like they just did to the patient what some of our clinician colleagues are like, did you not think that you could just, like, why not just increase your exercise? Why not just eat less? That will help you. That's essentially what insurance is saying, is that no, before we do gastric surgery, you have to lose weight, like as if they hadn't been trying, right? So it's a little tough, and I would say I write mean and nasty letters for appeals, and especially to our select health partners. But I think this is a great way of going forward. So then, as we kind of think about it from a complication-centric model here, again, this is ACE. It's no different than the prior up here, other than it's much more specific what it's doing. So assessing BMI, then a stage, and then implementing the plan. And they've broken it out nicely, what kind of things you're going to add in terms of the different modalities to help this person in their different BMI stages here, and whether or not they have complications. So again, you're going to intensify and ramp up therapies or add things to higher degrees if folks are further along in the BMI stage, and or if they have further complications and earlier complications. Okay, so I leave this slide for you to kind of look at, but I think it's really nice to be able to say, okay, what's a nice formalized way that I can just follow, and then depending on our clinic, do we have a way to refer to nutrition and dietitians? What's happened to Way to Health program? Is there someone that can help, like exercise therapists? And then all that, do we have behavioral therapists for counseling for this stuff, etc. And I think that way we can kind of build it du jour and appropriate to our clinics. I'm happy to work with y'all if you want to, collaborate. Okay, so
Yeah,
then,
I just have a quick comment, if you don't mind.
yeah.
So we did a lot of counseling in my last practice prior to bariatric surgery. And the major reason for the weight loss is that patients who lost between 5 and 10% of their body weight before surgery reduced their 30-day mortality risk by about 30%. And those who lost more saw even improved mortality benefit after surgery. So it is doable, but there is a reason that it's required, and it really is safety for the patient. And there are physiologic reasons for that, which I'd have to review to go over that. But it's not a, even 5 to 10 pounds can help reduce complications. And so while it is really difficult, it's still something that with with involvement with clinicians, we can achieve often through medications, but prior to bariatric surgery. So just wanted to add that.
No, that's great. In terms of, better clarifying why that's there, and there's some data, and there's always data with regards to those kind of things. And I would say, if done correctly, anyways, hopefully we have started this process, including counseling, well before we've moved towards just saying, hey, you should do bariatric surgery, right? So I do appreciate that, actually, that you're giving us the data of why, and importantly, mortality as the sticking point for that. Of course, my comments and then your comments really kind of come together, clarifying that I would not have just sent everyone to bariatrics without starting something or doing something. But the other side of it is that this is why we need comprehensive collaboration, because, again, not willy-nilly sending people, but rather showing that stuff has been done. They have demonstrated some weight loss. I like the fact that we have some pharmacotherapeutics that may be able to impact that first 5 to 10 pounds to get them comfortable with this idea. Okay, I can actually lose weight. That's actually mentally helpful for a patient as they prepare for bariatric. But I think there's going to be a hybrid approach here too. Don't you think, Leslie, with folks, because the rate of quote unquote recidivism in terms of weight gain often happens with bariatrics because we haven't quite modified some of that other, but still some of that endocrine dysfunction exists for those individuals. The body's going to try to defend some of that fat mass that it just lost like excessively in a short period of time. So I think that there's going to be a hybrid approach to some of this where we add a GLP-1 for those individuals at lower doses to help kind of stave off and get them through some of that first year and maybe the next couple of years even. I would invite your thoughts on that.
Right. I think medical management prior to bariatric surgery, and even using short-acting weight loss agents like phentermine, were helpful. Um, we know that there's not good long-term benefits with phentermine, but um, if you can't get a GLP-1 due to cost, there are ways we can help a patient lose weight prior to surgery. So um, understanding that weight loss through lifestyle efforts can be incredibly difficult. So.
Yeah, great. Thank you. Thank you. Okay, so as we move forward here, this is just a profile of all the weight loss medications up to the point that they had published this in 2023. These are, you can see those, right? Phentermine, orlistat, naltrexone, bupropion, phentermine topiramate, liraglutide, and then semaglutide. And of course, this does not currently, this was before Mounjaro and tirzepatide, because that was purely a diabetic drug until this year with Zepbound, which is the weight loss FDA indication for weight loss for that. So that's why it's not on here, even though it was recognized as having 20% weight loss as a diabetic drug. But you can see, I mean, these don't even give really an idea of the access and cost of these. If you were, paying attention, and some of these patients, the out-of-pocket cost for Wegovy is nearly $1,500. And so, no wonder folks are trying to do compound at $250 a month. And we'll kind of talk about that, but it's kind of nice to, in a nutshell, to see like the utilization, the mechanisms here. So I leave this here. The potential side effects, I would say, in general, when you start messing around with hunger and satiety and you're delaying gastric emptying, some of that nausea and vomiting, while it's kind of a side effect, I think I'd almost call it a feature instead of a bug, at least initially. Meaning it does kind of lead to like not wanting to eat, but ultimately if you dose it correctly, most should get over that initial kind of these side effects, and some may still have some lingering, even if you dose low, etc. But I would say the experience I've had thus far, and Leslie's had much more experience in the space, is that, yeah, everyone kind of gets these with their very first dose, even at a low starting dose. And then that's why we're doing it titration, Q4 weeks, really, at least minimum, I think is helpful is Q4. And then you go to the next dose and kind of see where people are for the next 4 weeks, and then so on and so forth. Okay, so here are the oral weight loss agents that are out there. So we talked about orlistat, and I would say this is commonly by a buddy of mine called orlishat because of what it does. It inhibits the gastric and pancreatic lipase. So often you get really runny poo that's oily. And I don't know if you all remember a time where there was a potato chip out there that had orlistat. And, when a caution is anal leakage, I think that's a problem. But I mean, it can be effective. It can be effective. I don't know that it really crosses the 5% weight loss threshold, but as an augment and an adjunct, it can be helpful to folks, and can affect your lipids, right? To a, I guess, beneficial, but not necessarily to cardiovascular risk benefit, but you'll see changes in those numbers. It's FDA approved for weight loss. You can kind of see the ages there, as low as 12 to 16 years of age, and it's approved for long-term use. So not short-term, like, oh, I'm going to use it for a beach body. The funny thing is this leverages the idea that obesity is a chronic disease that should be chronically managed, and yet we still kind of have this holdover that it's just a choice issue. Okay, so here's just some of the trials that were out there. I mean, here they're showing up to 10% weight loss, but I don't think that's really that common. And maybe Leslie, if you've used that or prescribed that, not used, maybe you've used it personally, but prescribed it, if you've seen that in those patients at all. Okay,
Yeah,
so
I've used it very
uh,
little, but yeah, yes, I've heard those reports.
hopefully not seen them, but heard them from your patients.
Correct.
So here are some of the contraindications, and this kind of makes sense. Hypersensitivity to a medication should be a contraindication, but cholestasis, chronic malabsorption, because again, that mechanism here is that. Whoops, sorry, I don't mean to make everyone dizzy there, but it's inhibiting gastric and pancreatic lipase, and so you can potentially have a problem there. In terms of these other um, issues of cholestasis and then chronic malabsorption syndrome. If they already have that, probably not a good idea to exacerbate it with orlistat. And so here are some of the side effects. Again, you're going to have these, and we're not getting CME for pharmacology, but it's always helpful to kind of know these. You'll have them to kind of come back and look at them. On your own. But here are the pearls. So there are a few case reports of acute hepatic failure or hepatocellular necrosis. And, just remember that when you're deploying these in patients, they already come with their other diseases. And triglyceride is a common thing that's traveling along with obesity management. And so just be careful and selective of who you're using these therapies in. But it's not common. These are case reports. So it's not like, oh, for the fear of this, like one in whatever, just watch for it, right? And know, and don't be surprised when it occurs, but rather don't expect that it's going to happen. Okay. And then sometimes you'll have some changes in glycemic control. For these patients. Again, here, if you're taking multivitamins, then, I don't suggest multivitamins, but if you happen to have patients that like multivitamins, then really you want to make sure that they're taking them beforehand, well before 2 hours, and then afterwards, so that it doesn't because this orlistat's coming through and you're not going to absorb any of that. Okay. Same thing if they're on cyclosporin, and in particular levothyroxine. They're probably folks that may be hypothyroid or be treated for hypothyroid when who knows, it may not be that they have hypothyroidism, but they're using levothyroxine. So it will change that dose. So here, again, during or up to 1 hour after meals containing fats. And then if you, if you have a meal that does not have fat, so someone that's already kind of like high salad diet and low fat, this is probably not an effective therapy, because that's what you're trying to do, is reduce absorption of those kind of things. So here's naltrexone bupropion, or Contrave is the FDA trade name for it. We don't really know how it fully affects weight. I mean, you know what a naltrexone is, and you know what we use bupropion for. And I almost kind of think the bupropion kind of follows along the smoking side of things, where maybe there's an addiction component that you're overcoming with bupropion. But I don't know necessarily I understand the naltrexone side of things. So here is the research that kind of went into this. Again, I don't think it's common to get up to 10%. Most of these therapies that are non-GLP-1 at best were at about a 5% on a regular basis if they were going to have any weight loss. But you can kind of see the match component against placebo. And you'd say, well, actually, when you put people in a trial and you add diet and exercise counseling, folks do lose weight. And or if they think they're on a therapy, they start to do things to lose that weight. So anyways, you can kind of see that in the naltrexone bupropion. Again, more here, but they added a behavioral component. And so you can see that it gets closer together, 57 versus 43%, whereas over here, 48% versus 17%. When you start to add a behavioral component in counseling, that can certainly impact how, weight loss itself. Okay. Contraindications, of course, if you have an allergy to bupropion or naltrexone or acute opiate withdrawal, that's unkind to folks who are on opioids chronically. And then, of course, benzos, barbiturates, etc. If they do happen to have an underlying eating disorder, those things, I don't know that we're managing those individuals, but just kind of think about that. If you are thinking of doing weight management with folks. Again, just other contraindications here. We always see the MAOIs. I have not prescribed an MAOI, I don't think, ever in my career of 20 years. So then here are the side effects that are possible. Again, kind of features, bugs, etc., as you're kind of messing around with the satiety and hunger side of things. Adverse effects, just to be aware of. Again, hypertension tends to be the highest one here at 3%. And then here's the black box warning, right? In terms of folks that have major depressive disorders or psychiatric, you kind of worry about maybe suicidal thoughts and behaviors across the board. So here, follow up. I think this is in everything. Really, these are kind of general principles, baseline body weight, and then within 12 weeks. That if you don't see any changes, then it's probably not the appropriate therapy after 3 weeks, or I'm sorry, 3 months of therapy on this. And then checking blood glucose. Yes, if you're messing with weight, that's going to be something. If it's a type 2 diabetic or type 1 on insulin, they're going to have to manage and change based on that weight loss. So then all of these other follow-ups here. So here are the pearls. Again, recognizing that there is a black box warning in terms of suicidal ideation. There's some reports of seizures or tachycardia, and then acute hepatitis. Again, if you're using it in certain populations where triglycerides and they're on other therapies that may affect the liver, this can be problematic. And then I think, yes, certainly if it's in an elderly population of advanced age, just be aware that that can be problematic. So here's Qsymia. Oh boy, we've only got 4 minutes. I apologize. I spent so much time on the front end. But phentermine here is, your releasing catecholamines and thus decreasing appetite and food consumption. Then topiramate, we're just not sure what that is, and I think maybe more towards kind of the behavioral component of addictions might be what's going on there. It is Schedule 4, so it is a controlled substance. So here are the trials, and you can see there is some evidence that there's benefit, right, in at least 5% weight loss or less, or greater than or equal to 5% weight loss. Not so much on the 10% side unless you get up in dose, and then really you got to be careful and watch these folks. Here's the Conquer trial. Again, same thing. You've got, this is out to 56 weeks. So you have people at the year mark. And, there's some persistent weight loss that folks have. So, not to poo-poo these therapies. And Leslie has kind of talked about how effective they can be before bariatric surgery to lose weight. And I think that's great. I mean, 5% of someone that's in the 400 range, that's going to be more than 5 to 10 pounds, right? So here's some of the contraindications. Again, MAOIs. And then here are some of the serious adverse effects to think about and watch for. I didn't get to my favorite drugs here, and we're coming up on 1258. But as we kind of think of other contraindications here, please, again, as I kind of discussed, or I guess I didn't discuss it with Hero. It was the last time I taught this in a class. But we probably shouldn't be thinking of weight loss in patients who are pregnant. If you're thinking about that, maybe maternal fetal medicine and OB-GYN should be involved in this if there's some issues with weight. But that's not something that you and I are probably going to be messing around with. But just know that it's contraindicated and then potentially unsafe if they are, breastfeeding. So here, I think the pearls are, and this happens a lot with topiramate, actually, where you can have things that happen with acuity, visual acuity, and cognition, and a lot of that will reverse as you stop the topiramate. So it's less a phentermine issue, but topiramate. So diabetic patients, again, hypoglycemia, if they're losing weight, it's problematic. Don't suddenly discontinue. So topiramate has a dose down titration schedule to it. Okay, so locasirin was out there. It's been rescinded. Okay, so in terms of the incretin, maybe I will record a separate thing on this. It probably was the thing that you were most interested in, I think. But in any case, just so you know, these are Zepbound is the kind of the latest entry into the market. This is tirzepatide. It's a dual incretin with GLP-1RA and GIP, whereas semaglutide is a GLP-1RA by itself. So you've heard GLP-1, GIP. You know that it's part of our satiety, but Zepbound is basically the exact same. The dosing is the same, etc. It just has a specific indication for weight loss, and we'll hopefully see pretty soon its impact on cardiovascular disease. I did, I'll stop here because everyone's got to go, but just again, reiterating that last week, as we talked about cardiometabolic, semaglutide in particular, that pharmaceutical company has won out in multiple trials. Select trial was not Select Health. I almost said Select Health. Select trial was in non-diabetics that had cardiovascular disease and a BMI of greater than 27. And it was the Wegovy 2.4 milligram dose. We saw a separation of events. And so it now has the FDA indication just in cardiovascular disease for people with BMI greater than 27. So some weight loss there, but the benefit was seen even in those that had minimal weight loss. And then for the FLOW trial, for our CKD treating folks, that again saw a decrease in progression to end-stage renal disease in folks that were on semaglutide. Same dose, I think they went to 2.4 milligrams. So I think we're going to see this. It really is going to be a class effect for those that are in that long-acting 1 week injections. we didn't see it really with dulaglutide, Trulicity, and that I've heard some news that might go off the market. And then liraglutide is the once daily injectable in this space. So, any questions from the group? Okay, I just know that I have nearly 35 more slides, or actually 45 more slides. And I'll drop this into the chat for you all. I'm sorry, I really wish I would have taken a little bit, would have moved through that a little bit quicker to get to these injectables. But I wanted you to get a sense of where we're at in terms of obesity, how it impacts everything. And really, it was nice to go through some of the historical that are still around. They're effective drugs, but I think here, the incretin therapies are going to win out across multiple different diseases. So thank you, everyone, and I appreciate you sticking with me to this point.
Thank you.
Thank you. Thanks for your comments, Leslie.
Oh, great.